Welcome to Grand Rounds. Today, please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations that you picked up on the way in, and give us any ideas you might have in regards to future topics and future speakers. The CME community is always appreciative of those ideas. Today, I have the pleasure of introducing Dr. Rahul Rastogi. Dr. Rastogi is board certified in anesthesiology and pain medicine. He currently is the Director of Pain Medicine and Clinical Professor at the University of Iowa, and he kindly has accepted our invitation today to drive over from Iowa City and provide us with an update on on chronic pain management in the acute care setting. And please join me in welcoming Dr. Rastogi.
Thank you very much for the introduction and giving me the opportunity to come here. Of course, this subject is passion for me. So the topic which has been, of course, is a very hard button topic, and always we run into difficulty. Every practitioner, the chronic pain management in an acute care setting, and so. I'm sorry, I need to. So I don't have any specific disclosure, except as an educator, I use all the information available wherever for the education purpose. It could be journals, it could be textbooks, it could be web. So some of the pictures or some of the information you might be fully aware that it could be from. Sorry, I'm just. So I was asked for learning objective. Of course, there could be so many. So these are the 5 points which I chose, but it could go beyond this. But mainly, what is chronic pain, and understand the challenges actually faced by all practitioners in management of that. What are the management modalities which is utilized, and what are the difference or what we need to do when the chronic pain patients show up in our acute care setting, and how to plan the transition. Once they are treated, go back to the chronic pain management issue. So I think this topic attracts attention because of start from the definition. So I'm sure everybody's aware, but just to completion, this is an unpleasant sensory and emotional experience. So we are not talking about disease, we are talking about experience associated with actual and potential tissue damage. So it could be no damage at this point, but potential is there. Or describe in search of damage. So how clear is the definition? And so we can really figure it out, one medication which can take care of it. And that's where all problem starts, because we try to find a solution for the experience. So whatever we do, whether we like pleasure, whether it's pain or any other psychiatric issues, whenever we talk about experience is not one entity. It is a mixture of so many other emotional, learning, physical components. So pain essentially is a biopsychosocial disease. So there is a physical component, there is a social environmental component, and there is a psychological component. So if we deal with that type of disease, we have to deal with all three, and maybe the fourth segment is spiritual now. We need to manage all four together to get the benefit. Sometimes pain just out of lack of knowledge or out of practice pressures, we think pain is the response of some stimuli or the tissue injury or nerve injury or some disease. As we already talked, it's not. It is the cognitive experience, and it is generated by whatever the way you want to understand pain, what is the etiology of pain, what is the significance of this pain in your life, what is the duration of pain, and threat to your self-image. Like if I am if you are from the Oriental culture, the person who's the head earner has that image, and if they are in pain and they lose and they get disabled, they lost their influence. Availability of the treatments, because it all depends. If you are in deep rural Africa, you may not have those treatment available. That is pretty depressing, even though if you know all those things. that there is a treatment available. But if you live there, so these are the factors which affects this. How we feel pain, there are multiple ways you can explain. But if we are all science students, so we always try to follow the science. So we go for the pathway. Where I need to point to is on this. It's okay. So you start from periphery, and that's where the noxious stimuli, which creates the action potential at the nociceptor, and then they transmit to the spinal cord, and eventually it goes spinothalamic tract, and then reaches up to the cerebrum. That's where the perception happens. That's the one arm of the pain perception. If we have only this arm, we are in big trouble. Even the small little air movement could be very painful. We also have the modulation of pain, which is the descending pathway, which is modulating the pain at the spinal cord level. And sometimes they are inhibitory signal, majority of the time. Sometimes they are a stimulatory signal. It depends on, and that creates the gate. If you hear, you must have been here for a long time, there is a gate theory, and that's what, so it creates gate at the spinal cord level. It is actually the summation effect of the descending inhibition and the peripheral stimuli, and then final, what do you get at the perception? You can cut this cake in multiple ways. The most common way we describe is these are nociceptive. What that means is on that pathway, we are stimulating the nociceptors there. And that start the whole cascade, and that's the nociceptive pain. Or the neuropathic, it is the nerve directly getting affected, not necessarily the peripheral nociception. Or it is mixed. And majority of the chronic pain, at least which we are talking, are mixed. But as all my surgery colleagues, anesthesiology colleague, or anybody who deals with the postoperative pain, that's essentially, in the beginning, is the nociceptive pain. And of course, mechanism is a little different, management is different for all those. So you can cut in different ways on the basis of duration, whether it's acute pain or the chronic pain. And again, there is no clear-cut definition for or duration given on that. And consensus is anywhere beyond three months, it is considered as a chronic pain if pain is persisting. Acute pain essentially is the physiological pain. It is the reflex response of the body against the changes which is affecting the physiology. So it has a purpose. Chronic pain is not necessarily the reflex pain or has a purpose. It is you have injury, your tissue heal, you're functioning, you still have pain. And you can do whatever the diagnostic tools you can utilize, you will not find any other thing wrong. Again, that's the chronic pain, and that's where that pathway comes in the modulation, and we will go in a minute on that. So the chronic pain is the resultant of the central sensitization path, means the modulation which is happening in the spinal cord is getting affected from the barrage of the signals from the periphery, from the less inhibitory signals from the central nervous system. So, and this process, this imbalance starts within 20 minutes. And there are several studies that's been done. So it starts with the sensitization at periphery, which you see, say, common example is shingles. Nerve get damaged, but the severe allodynia is not correlation with the nerve damage. This is the modulation at the peripheral level and creates the same sensation, which should not be that painful because of so much of overstimulation or ectopic stimulation caused that peripheral sensitization. When this barrage reach at the modulation channel at the spinal cord level, leads to altered modulation and result in central sensitization. And that is you can say in simple word, the basis of pain, chronic pain. So pain, why we talk about pain? I think this is, not just I think, it's enough data is out there, is the most common reason a person seeks medical attention. And pain, I'm not differentiating, the chest pain is different than any other pain. That's all together. So if more than 40 to 50% of patients in routine practice actually fail to achieve the pain relief because the limitation of this science, limitation of understanding, complexity of or multifactorial component. If you look at this cartoon, so chronic pain remains the most expensive disease, whether in 92, whether this is the 2011 data. So in 2011, combinedly, cardiovascular, cancer, and diabetes, all three combined, the chronic pain is way much more expensive than that. So it's a significant burden in our socioeconomic structure of community also. And looking at the prevalence, again, it's every human being go through acute pain in their lifetime, period. Maybe just for a minute, or it could be lasting for long. More than 80% people have a episode of chronic pain, which is lasting or lingering for a long time. And on a given time, 1/3 of the total population of a country like America in our situation is suffering from chronic pain. I mean, just count the numbers, how it could be. And it results in more than 50 million workday loss per year. And cost we already discussed. And this story is not in US. Its story follows, so there is European data on the bottom, essentially same. Challenges, why it is? One thing we already talked is start from the definition, because we don't have a very clear understanding what is exactly pain. Are we mixing so many things together? And we didn't have any definition, so we put this thing as a pain. Or they have a multifactorial component. We already talked about the mixed nature of pain, nociceptive or neuropathic or psychogenic, or all of them are together, and they are could be three different diseases, or could be one disease which has all three components. And it is an experience, so it requires the human interaction. That's where it comes in the compliances and the comorbidity, because they have some other diseases associated with it. The same thing for polypharmacy, because of the last molecule which is invented for pain purposes was tapentadol. That molecule was discovered in 1983, although it comes in market just recently. So we are now 30 years later. We don't have any other molecule which is depicted mainly for pain. That itself tells, even though so much of money has been spent on research of that, we don't have extra. We will try to find out different small molecules of a different mechanism, but not a general umbrella term called pain. And of course, all of us are aware about the reimbursement issue and the practice issue. So barrier of treating pain, it goes, every stakeholder who manage pain has influence and create the barrier. But biggest barrier is patient himself. And that depends on where they are and what cultural belief they follow, what the means of pain is. Because if they don't come to us, you're not managing it. They are suffering it still. But saying that, we should not discount that. We are also very big culprit in that, which is physicians. So in 2001 and repeated in 2011, the American Pain Society did the study, what is the biggest cause? So they didn't ask the cause, they asked for so many different variations, and believe it or not, even in 2011, the top reason of undertreatment of pain is lack of knowledge about the pain, complexity of pain among practitioners. Significant issue. Yeah, I know before that, pain was not a part of curriculum, but now, at least from 2007 onwards, pain is a part of the medicine curriculum. I think the change will happen, but at least we have not seen yet. Impact of pain, whichever the way you want to say, every single part of the body get affected by pain in a negative way. There is no positive impact of pain in our body, whichever the system you pick. Or that's personal. The physical component or the social component is also involved. I mean, I can run across so many patients who are disabled and they lost their livelihood, and now they were doing very well. Now they have economic issues, so they cannot get the management. So it can be done in various settings. It can be found in various settings, whether inpatient, outpatient, in inpatient also, whether it's just a patient get admitted for, say, pneumonia, but they are having low back pain, or in a operative setting because of we intentionally, for therapeutic purpose, creating that injury. Outpatient, of course, either is a trauma or the post-surgical or the medical reasons, and emergency room. Of course, this all variation can be even more get complicated by when we count on the association of the comorbidity, several medication, and an average person, which I see in clinic as a chronic pain, they are already on 8 different medications for different reasons, irrespective of pain. Opioid issues, which is all of us aware, and the substance abuse disorder. And I think these two are the main hot button topics that at this point we are running into. Whenever we try to manage pain, whatever the biases we have, we should leave the bias out of the room. We should at least try to believe patient first, and then put the rationale behind in a much more unbiased way. So we should believe the patient, and we only way to assess, to recognize that pain is the repetitive assessment. I'm sure everybody gets surprised, or have experience or get surprised in how many times patient you have seen, and then suddenly you get the key point after 9 visits. Even though you are asking much more different way, they are not able to communicate, or they don't want to communicate, whatever the reason could be. So, and that could be the deciding factor. I come across with this thing very commonly, so I think it's same thing for all of you, most likely. So the biggest thing, although the way we have set up the practices, at least in university here or before I was in WashU in St. Louis, the same, that eliminate this issue. But in general, the referrals which I get for all our, if we are not triaging it, essentially it is because of they have difficulty of either managing the pain, not managing the pain, it's the managing the medication is the issue, whether the patient has taken so much of opioid. So you can see the undercurrent. Concern is not the pain, concern is the management of the medication. So and this is a slide I borrowed from Loza in '99, and it is still relevant that negotiating, prescribing, optimizing opioid analgesic is not the pain management. Anybody, not just physician, every health provider has a responsibility to manage pain. Medication is not necessarily the reason of managing pain. And it become more relevant because it was getting worse and worse on that. So this is also Lozer's first 3 point is also from Lozer. So he is the neurosurgeon, if anybody don't know, from University of Washington, Seattle. He's retired now. He's one of the 5 pillars of pain who kind of establish pain. So his first thing is everybody know we should not do any harm. But there is a reason of this order. So, and when we're trying to manage, and I strictly follow and we strictly recommend that, we try not to reduce pain. This is not our primary responsibility. Our primary responsibility is to make the person productive. I always tell, and if you give enough time to the patient, ask, so they will come, okay, I have a back pain. And if you don't speak, so they will come up, I have a back pain, so I cannot bend, so I cannot enjoy my grandkid. Problem is not back pain. Problem is he or she unable to enjoy the grandkid. That's the function issue. Pain is the way they are trying to approach, because they cannot go to any person to get treated. How can I enjoy my grandkid? And we need to understand that. And you must have been already come across, and I see all day long. People are not interested in pain control. People are interested. You have enough other patients also. But they are more interested in the quality of life and the improved function. So, because they have their own issues. So essentially what you're trying to do, you're trying to find the balance in their life, in their experience, along with the use of medications. And so this cartoon, which is saying me, so in this study by GAN, 47% of the people are not interested in pain medication if there is a balance between the risk for the pain relief versus the side effects. They are very happy to get rid of the medication and be in pain, but not to have the side effect. And this is general population, which is, again, it's an eye-opener. Because we sometimes come in this, okay, take this medication, that medication, that medication. You have constipation, take naltrexone. If you have this, then you can take this. We just keep going on without asking what patient is actually wanting. Because we assume that patient came to pain clinic, it means he wants to get their pain better, which is not necessarily true. There are multiple modalities. I usually tell my patients there are only 5 modalities for every medical problem. Either we can do the medication, we can do the injections, we can do the surgery, we can do the holistic medication or psychological therapies or physical therapy. But again, this is a broad umbrella thing, but those are essentially, if you think broadly, every other thing fit into those. Not a single one modality is not, can be successfully, you can apply for management of chronic pain. So it has to be multimodal, that you use these things, all these tools in tandem to get better response. And because of your approaching or trying to attack multiple mechanisms, by this way you can decrease the dose of the more higher side effect agent. And if the medication, if he or she is not getting better, still you need to use the non-pharmacological means. So, again, I'm sure everybody is aware at this point, every day, even is in the central, in the main journal media. So, although this data is a little bit old, it is from 2012, still 40 deaths in US from prescription painkiller abuse, which is a single death is too much for every healthcare providers. We are there to not do harm. But if any of us is writing prescription and lead to this, sometimes you don't have control, but majority of the time we can be more judicious and more cautious of doing that. And if you see that the death is keep increasing, since 2010, the death from the substance abuse is higher than the death associated with the traffic accidents in the US. So very grim number. So if we are managing, if we go back to our same, how we feel pain in a pathway, so either we can eliminate the source, which is at the nociception, not having nociception. That's the easiest way, but majority of the time in chronic pain that doesn't follow. Or we can use various other modalities at different level, block the transmission, change the modulation, use the medication which is effective centrally, or use psychological therapies to alter perception or coping skills. As we talk, multimodal anesthesia is the way to go, whether we are doing the acute pain component when patient is there, after post-surgically, or for chronic pain. And as we talk, it's a biopsychosocial disease, so we will be utilizing all different modalities at every level. Because it's just not nociception, where you can block, you can use other medications to prevent this staging of the pain, you can say, and which goes up to the environmental effect. This is the ladder which has been implemented for cancer pain. The first 3 segment, the lower segment of this, for cancer pain. For some reason, because of the lack of other tool, in 1989 or 91, practitioners have thought, oh, it's working in cancer pain in 70% people, why not we use it in chronic pain? That's where the opioid crisis, the seed of opioid crisis started. Then later we thought, okay, we can pursue that, but we will do the intervention. That was the mid-90s. But we realized that by the time we reach into the intervention, we are already failing. So the model has shifted that you can use the intervention all across the time. You should avoid this ladder if it's possible. If you have an intervention, of course, least invasive to most invasive on that. So in our armamentarium, the simple things are analgesics, which we commonly use, and I will not go too much in this because almost all of you know, the commonly used medication in the pain practice is, of course, non-steroidal anti-inflammatory drugs, acetaminophen, opioids in some places, or adjuvants like antidepressant, anticonvulsants, antiarrhythmics, GABAergic agents, and so on. Mechanism, again, it is little. This alone will take my whole 1 hour, but so the simple thing is, I will go by medication to medication. So this is just what we feel when we see patients, that opioid is, and we are talking about the evidence base. We are not just, okay, because I don't like that color of the medication, so I don't want to prescribe. No, I have no issue with that. So for most of the pain which we see is musculoskeletal, and I'm sure all of you, the first line is usually anti-inflammatory for short term in acute component, but if it's a chronic, then you will try to use either the antidepressant or the non-pharmaceutical means. For myofascial, if just especially only muscle, not the skeletal component, then anti-inflammatory and the muscle relaxant are the way to go. And in neuropathic, there is no role of anti-inflammatory. Unfortunately, I see a lot of consults or referrals where patient is strict neuropathic pain, and they were taking Celebrex or something for a long, long time without much benefit. Opioid is not the primary thing. So I think I put this slide too early, but I think it is needed. So most common thing is Tylenol. We don't know the exact mechanism how it works. We assume multiple mechanisms. Of course, IV and oral is essentially same. Of course, only thing how you can mode of delivery is the reason. It become a talk of the city or talk of the country 10 years ago, because this is not just the end of the list. This many products, not all have considered as Tylenol acetaminophen. They have so many other things, and all of them has acetaminophen somewhere, and they lead into much more bigger issue of the dosing, and that's the reason that recommendation comes to we should not be using 4 grams per day if you are using intermittently and seldomly, but if you are using regularly, we should not cross 2.6. So from our clinic, we see all the time, because we see patient in chronic, so they should not be taking 2.6. Non-steroidal, again, almost everybody aware about this COX-1 and COX-2 issues. This is the selectivity. As it becomes more COX-2 selective, it becomes a heart problem. The more COX-1 selective, it becomes a renal issue. But that is not that clear. And some of the medication, just pay attention. It's meloxicam. We still use. This is a much more selective CO2 component. If we are using for cardiac issues, I think naproxen has the least side effect on that. So again, it has an association with the cardiovascular bleeding, GI component. This is the reality, hit the reality right on where it belongs. Which medication we prescribe 1 out of 1,200 fatality rate if you take it for 2 months regularly. Every medication goes out of market unless they are the lifesaver or no other treatment is available like cancerogenic medication. We know that thalidomide is still available. So this is a very grim numbers, and it has been replicated multiple times. This study was done in 2001, but it has been replicated multiple times with almost similar numbers. So I think that's a concern. Antidepressant, not all antidepressant has been used for pain, like especially SSRIs has not any role in chronic pain issue. SNRIs are the best of those because of the side effect profile. Otherwise, tricyclic antidepressant, at least in literature, has shown much more efficacy, and this has been used mainly for the musculoskeletal pain and the neuropathic pain. Anti-epileptic drugs, again, being utilized very commonly, like candy. But if you look at the efficacy, if you are taking out the diabetic neuropathy or HIV neuropathy, maybe that the group is, I'm not talking about for chronic pain, efficacy is not that great. Although it has shown if you have a chronic pain patient and you are taking it for acute care for some other reasons, either for surgery or anything, it has shown that if you use gabapentinoids, whether a pregabalin or the gabapentin, it modestly decreases the requirement of opioids, and the pain scores are better post-operatively. So it is very commonly used nowadays. A side effect is still drowsiness, so if drowsiness is not an issue, then it's fine. Opioid, again, mainly the mu receptors, which is we are targeting. It is present in central and the peripheral spine, peripherally also. So it affects, once you take it, it affects almost every receptor. And some place it has a positive role, some place it has a negative role, and majority of them are negative role. So that's the reason we run into this all other side effect issue. Good part of opioid, and I think that's the reason it become popular, that it is available in various formulations, and you can deliver by any means, what you know, route of delivery. But that's what we want. You want the balance between the pain relief and side effect. But in reality, we are in different thing. Well, because of the side effects are so pronounced with opioid, we seldomly get the balance. Very, very rare. I can tell you, I'm doing practice for the last 20 years, and I can count 3 or 4, 5, maybe 5 patients. And you need to understand, give me my age factor in it. There was a time when I started, opioid was a miracle drug, so almost everybody used to get opioid in 99 or 90s, late 90s, because we don't have all of the, still I have seen this imbalance all the time. And it affects, it's common side effect, these everybody knows, sedation and constipation and addiction and all those things are there, but as a physician, pain physician, I'm not concerned about those. I'm concerned, but that's not the main concern of not writing opioid. It is this. And this list is, so I still didn't put because the data is not that strong. So dyslipidemia and the cardiac risk is now adding up on this. There are a few case studies and few reports are out there, but every single endocrinal function goes down. It affects immune system by multiple means, through the endocrine axis also. There is a data for the cancer progression. It is not shown that it causes cancer, but if somebody has a cancerogenic cell, if somebody has a carcinoma in situ, which is not metastatic, you can turn into metastatic. And there is a reason behind that. And yeah, of course, it causes the neurotoxicity, which is everybody aware about, the opioid hyperalgesia. So this is the endocrinal side effect. It goes through the HPA axis or HPG axis. And it creates, if you pay attention, almost everybody. So by definition, if somebody is taken for more than 3 months of opioid, by definition, they are hypogonadic. So if you check the level, this study has been done from Denver almost 10 years ago. So this is the one hormone that easily they can check, but I'm sure all other things are there. And as everybody aware, the endocrine is not just a simple thing. They are the regulators of our normal function of body at every level. Same thing, immune downregulation through the HPA axis or the sympathetic drive. It can lead to the internal effect or the external effect, either the autoimmune issues or cancer issues happening because of this, or it will lead to allergic reaction and increased infection because of the immune downregulation. And cancer progression, as I talk about, there are it happens because of the MOR receptor and the vascular endothelial growth factor, which is responsible for the angiogenesis and tumor cell proliferation. Especially these studies are all done in breast cancer. So at least for breast cancer, very strong data is there. Opioid hyperalgesia, again, this is the problem, which the earliest problem we recognize with the opioid. Now we have so many other things, and it has been, essentially it is a diffuse body pain. So you start with the one single pain, let's say wrist pain, but with the opioid, eventually they turn into the diffuse body pain. So whenever you have any opioid patient and they start talking about some other different pain, and give them time. Of course, any human being can have some other pain, not because of they are on opioid for other, but that's a point of concern. Again, very long topic. I just put that slide, so at least if you are interested, you can go on that reference and read about that. So anything which we want to do with the opioid, first question is to ask, why opioid? Where is the evidence? And these are just a sample of things which is given. So this is the study or meta-analysis done in 2015. Opioids, so this is their conclusion. So it's not my words, but I believe it. So they made this strong statement where inappropriate and multimodal treatment program may be required. So they have done significant number of studies and significant number of patients has included. This is 2015. Another 2015, this is published in Annals in Internal Medicine when Chow had looked into, again, evidence, insufficient evidence to determine the effectiveness of the long-term opioid. But it's the so they didn't have the evidence for the efficiency, but they have that the risk is associated, a serious risk is have association with the dosing of the opioid. This one is done, just published just recently, actually, almost half a year ago. So this is, this group, which who published, is a pro-opioid group. So I'm sure you may not be knowing, but we were still, important pain relief was not observed within the dose range of 40 to 240 MME, morphine equivalent dose per day. But it has, if you read that, so many other negative factors. These are the recent data. So this is the, so I'm not sure how many people know Jane Ballantyne. She is the most pro-opioid person I knew. She was the chair at Brigham, and now, I don't know, now I think she's in University of Washington somewhere. So but she was the editor of Pain Journal, which is the highest impact factor in pain. She wrote so many pro-opioid, but this published in November 2006. Although it's an epidemiological study, but the country which we are talking, it has a very unique thing that any single opioid has been prescribed has required the national registry. So data is very strong. They look into 10 different factors. And that, so I just put some, like, just like looking at the employment, I think I didn't put in this. So, but or their self-health or the functional issue or any other things, or with pain relief and quality of function, none of the 10 of that come to significance, and pretty huge number. And if we have a patient, say, still we are stuck, we have to use opioid, we decide because of we don't have other things, pain is a debilitating thing here, we can give a short try. We need to still look into how we want to. First thing is, simple thing is, you need to do the risk stratification. I mean, whatever the tool you use, it doesn't matter whether you do the risk assessment tool or SOAP or anything. So you need the, essentially, sorry, I think I keep doing. Full comprehensive history. I don't prescribe any opioid except the terminal cancer. Don't take that people in that without the psychological screening. Every person goes through psychological screening. And I ask specific this question. They go for different behavioral assessment tool, and then afterwards they have to do the maintenance tool. And we decide on the basis of what is the risk. So if risk is less than 4, we follow these things: opioid agreement, urinary drug screens, prescription drug monitoring, and at least every 3-month prescriptions or reassess. And otherwise, almost same, but not 3 months, it's more frequent. And if it's an active use, and why we want to do that? Because if you're not gaining any ground, short-term benefit is not there, they're already on there. So if somebody's on opioid, the issue is how to taper. Multiple way of doing it. The most common way is if they are on the long-acting, short-acting, you decrease long-acting and slowly go up on the short-acting. So you keep, so you decrease this, keep the short-acting here. You decrease this. You slowly after 1 week, or whatever the time frame you use, decrease short-acting. Again, go up on short-acting when you decrease the long-acting, and eventually you can come off. This is the easiest, non-stressful way. Till we, only good thing is if you're decreasing less than, more than 10%, equal to 10 to 15% opioid per every other day, risk of withdrawal is minimal. Substance abuse disorder, again, they are associated with so many comorbidity, and they challenge us because of the substance use issue itself is a a significant multifactorial disease in itself. Addiction is not just the same as pain is a biopsychosocial disease. Addiction is not just one thing. It is also multifactorial. So if we are using, if somebody has a substance abuse disorder and come in acute care setting, we are dealing with acute pain. So there is no difference in any other way. We are managing exactly same way if they are not substance abuse disorder. Only thing is our vigilancy goes up, our transition goes up. If you're transitioning the patient, you need to make sure that they are on oral and they will be on the minimal most component and go back to their outpatient physicians. Essentially the same way, how we do is more frequent pill counts and all those things. If they are in buprenorphine, whether we stop it or not stop it, very concerned, especially in acute care, surgical setting. If somebody is the antagonist and agonist-antagonist. So essentially, you can multiple ways. If they are taking buprenorphine for a long time, you can continue it. If you don't have a time, but you can mentally aware that when you use the opioid, you will essentially needing around about up to 200 to 300% more than normal use of opioid because of its antagonistic action. Otherwise, best thing is to taper down, come off. Half-life is 24 to 42 hours, so you can supplement with other opioid to avoid withdrawal. And that's the best way. If they are using for addiction maintenance, then you will not touch, you will just manage it. And goal is to, when the acute thing's over, they should become off the opioid. On methadone, almost same principle. If they are for addiction, you don't mess with up. You just manage it as the acute component. But if they are on for medical purposes, then change into IV formulation. So IV bioavailability of methadone is almost 90%. So anytime when you change the rotation of any medication on any other formulation, you need to decrease by 50%, and that's what you're seeing. But it's a very complicated medication. I'm sure all of us are aware about because of the long T-half, from 15 hours to 170 hours. Which patient belongs to where, we don't know. So you need to be very cautious when you're using methadone. Same thing for the post-op pain in acute setting when we are using, if somebody is on opioid. Most important thing in this is, especially, and we always force it to do the pre-op. That's where you figure it out, you taper it, you can develop a plan of multimodal analgesia on that. But it can be difficult situation. Opioid can be used in the same manner which I talked, like it's acute situation you need to use. The role of ketamine is a point of concern, but there are some evidences has shown that it decreases the opioid use and reduce pain score. But in long run, it has not shown much benefit. And the next slide is able to tell you all whichever the way you want to use ketamine in fentanyl, ketamine with morphine versus placebo, they are not positive. So their response is not that great, and for long term. Another thing is the long-term use of ketamine is not indicated because of the long-term side effect. Other thing is lidocaine infusion. That can be a lifesaver sometimes when somebody's on chronic opioid, and especially these studies are done for GI patient, mainly the colon, and they had shown that it can decrease the hospital stay, reduce pain, and decrease opioid almost by 30%. Again, this has to be done under supervision, so it's not like you can run in floor. At least the data is not out for floor yet. So to support that, you can use interventional components like I'm sure you are fully well versed with the regional blocks or other short-term injections. That can help. That can decrease the opioid requirement. They can control the pain fast, and they don't run into somebody running with a chronic pain issue. You're not has to increase their use of opioid or any other medication because of the quick benefit, whether it's a back pain or any other nerve issue. This is the one thing which is I always see through. Majority of the time I see through inpatient setting because they come for the back pain, sudden increase in back pain, unable to move. although the controversy was created by NEJM, those two articles in 2011, although I can tell you with my experience, so I'm doing this thing since 98. So, and I don't know, the selection of the patient, which is used by Bushbinder and the Smith paper, both papers, those are the patients we don't even do the vertebroplasty. I mean, we have not done since 2001. I mean, we will be doing it, most likely we were doing it in 1999, 2000, because we don't know the clear indications. Because we realize that those patients doesn't get help. And that's so it essentially solidify our finding, which we didn't do as a study. So, but in my hands, I don't know, because we are doing for a long time, I have done maybe 5,000 of those over the last 18, 20 years. And my success rate is almost, it's not just me, all of us is 85 to 92% for pain relief. Function is a little different thing. Because of when you are doing, when a fracture is already happened, their biomechanical structure or forces has changed, they can have some function issue, but pain should not be restricting on this. Other multimodality methods, physical therapy, every single patient in the chronic pain goes to the physical therapy from me, at least. Not because of everybody needs physical therapy, but there is a data of the physical therapy, especially when you're utilizing the aerobic component, it increases endorphin that can help in their pain management. Another thing is psychology. That's also a very important tool. In alone itself has not shown that if you send patient only for psychology and you leave it, every other thing had not shown good benefit. But it is a good tool in multimodal component. And we should not and never forget about the education. And there is a studies that's done that I think I didn't include in this. So that if you don't, there is a one group in Sweden, they significantly educate them with the family versus they just discharge with a discharge sheet. Outcome is significantly different. I think because it's not just patient, it's the patient family, their caretakers, they are all important. And the better they understand, the better outcome you will achieve. And this is, if you want to know this is the opioid tolerant definition when we say it is somebody's opioid tolerant. This is one of my pharmacist slide, actually. I don't agree with these numbers, but this is what literature says. So this is what I want to share with you. Again, I'm open for all questions. Thanks. So, as I put that, there is no difference in outcome between IV and oral, if they can take oral. There is almost similar efficacy if you use IV. So, in Iowa City, I'm not involved, but I was the PNT involved in WashU. We did the trial, and then we decided, as per utilization, that they should not be offered. It should be very selectively when you really have the difficult situation that you don't have access by any other means. Even the study which we did on 50 patients, per rectal Tylenol and the IV has same efficacy. So I personally don't recommend, not just, I think if you are only talking about this a molecule, I think it's fine. You can use whichever you want to, that's fine. But it's one thing is invasive, other thing is you are exposing to we need to look at the socioeconomic cost also. Yeah. Yes.
You didn't mention benzodiazepines. A lot of patients who have chronic pain also have a lot of anxiety. What do you recommend since the benzodiazepines and opioid combination is so dangerous?
So benzodiazepine for pain has never been there is no evidence for the pain management. I fully agree with the anxiety. We prefer anxiety not to be managed through the benzodiazepine. It needs to be used through the psychiatric specialized help, and that's where the SSRI and SNRIs come in picture. That the advantage of that is that at least there is evidence for those, in some of those, which help in pain also. That's the one thing. Other thing is, I think all of us are aware, mixing benzodiazepines and opioid is a significant issue. What we had realized in retrospectively, so in 2004, we were changing our business model in WashU. We looked into what are the group of the patient which we are doing this thing for a long time who were not responded. At that time, we were not very strict because they are managed by so many other people also on protocol. And we realized on our patient, on the people who are having opioid and benzodiazepine together, not that only they have the complication, which we already know, they didn't respond with the pain also. So in my practice, even so if I'm doing vertebroplasty, if I'm using Versed, I'm not going to use any opioid along with that, with the patient. Now I change, if somebody unable to tolerate vertebroplasty, I do the lidocaine epidural. So it become numb, and then I do, just because the outcome is so poor with other things. You have some question, right? I'm not sure this is directly only nicotine. Yes, but there is a data for associated with the just fumes versus nicotine also. But both of them has shown the increased neurotoxicity at the terminal nerve ending. We always see people who are smokers, they develop, in the initial studies that's been looked into, they develop opioid hyperalgesia way much more quicker than any other person. Any other questions? Thank you very much. Thanks for bearing me.